It's Paul Wisdom from Victoria. We are joined by Dr. Marianne Keenan from Philadelphia, who wrote many of the original papers on both surgery and phenol for the shoulder. We're going to discuss our first of our clinical trial on cryoneurotomy, looking at some proof of concept for the lateral pectoral nerve. Our literature review revealed that the lateral pectoral nerve to the pectoralis major is 100% stereotyped, layered underneath the pectoralis major, going around the blood vessels. The medial pectoral branch has a more circuitous course with multiple innervations to the pec minor, and the other muscles, such as the subscapularis, have multiple innervation or are hard to find. You can see it here. You can turn on your Doppler feature. You can see the blood vessels that course which the nerves run around. And on the bottom, you can see a lidocaine nerve block, which is our diagnostic nerve block to see if the pec major is truly the target before we go on to do a percutaneous cryoneurotomy. When we decide a patient might benefit, we do a diagnostic nerve block with 2% lidocaine, and you can see in this patient the range of motion is much easier after the procedure, and they are also noting reduction in pain. They are now a candidate for cryoneurotomy. She's therefore a candidate for cryoneurotomy percutaneously done through the skin at -60 degrees with our ball of ice. You can see the results at 1 month, and at 3 months I'm stabilizing because I feel less spasticity and more stiffness in the capsular pattern. When we do the cryoneurotomy, we get an immediate effect just from the freezing of the nerve before Wallerian degeneration takes place, which we know will last many months from our prior studies. On the left side of the screen, you can see he is trying to have his arm abducted. It's very stiff. When we ask him to actively abduct, he uses the other hand. 5 minutes after the procedure, he starts doing it on his own. Of course, this has not really kicked in fully yet. Wallerian degeneration will take place, and at 1 month we see significant improvement in abduction and forward flexion. At 3 months it's improved. He's also been actively using it and learning how to program his arm. When he sat up, he could only abduct about 90 degrees, but in the seated position with gravity eliminated, it was able to go overhead. He is laughing because his arm is moving so fast. For our third patient, we again see the before. She has a classic fast catch and a maximal range of motion in the arm, and she will have a diagnostic nerve block and go on to have cryoneurotomy. We do our cryoneurotomy at 1 month and 3 months, and we see improvement with Wallerian degeneration over time. The patient is also using it. We can now decide if we have to do botulinum toxin on some of the other supporting muscles and stretching and physiotherapy to get a better outcome. This is a proof of concept study as registered clinical trial that we're doing to show that this cryoneurotomy is working on the pectoral nerve. Here we can see in the blue you have the flexion movement forward with the maximum slow range of motion, which is the V1, and you can see the improvement in each case. We have the abduction in the red going from 95 to 140, 85 to 130, 90 to 145. We also looked at the modified Ashworth scale, which dropped significantly in all 3 patients. As you know, this is not a linear scale. And even at the end range, was this spasticity or tightness? We looked at the disability of arm, shoulder, hand, and the important thing with this scale is just to see that the numbers decrease on the self-appointed scale. We use the goal attainment scale, which 0 means you achieve your goal, 1 is better, negatives are worse. For hygiene, we had a 1, a 0, and -0.5, which is approaching. For sleep, you can see it ranges from approaching to better than expected. All the patients wanted to have better movements, and that was the one that was difficult to assess, as they nor we knew what to expect. Thank you for listening to our case. We expect many more to come.